Hi, and welcome to episode 4 of The Skin and Stitch, a podcast following two friends in their journey through medical education. I'm John, and today I'm joined by my co-host Mahak. In this episode, we'll be looking at some recent medical procedures that have made headlines, both good and bad. Let's get started and talk about some medical magic. So, welcome back, loyal listeners, to episode 4 in Stitch. We're still kicking.
After 3 episodes, we're still kicking, yeah.
Yep. I think they say, no, they don't say anything. I was about to make something up. Okay. So, there's a couple things that I wanted to talk about that are unrelated. First thing, before this, clean my ears. And so I want to know, all right, what is your stance on Q-tips for cleaning ears?
I understand the relief from, cleaning your ear via Q-tip. However, it's just pushing in the earwax further into the canal. And so I feel like it's like if you can just do it around, that's better, as opposed to pushing it farther inside your ear.
Yeah, for the record, I'm against it also.
Okay.
Don't use a Q-tip. You know who does use a Q-tip, and I'm going to out him on the podcast, is my roommate, apartment mate, whatever it's called when you're sharing the same space but not the same bedroom, Alex. And we'll probably have him
Q-tips
on this podcast. Yep. He actually does a lot of interesting work on child advocacy and like child research, but he is an avid Q-tip user for his ears. And I tell him not to do it, and he still does it. So note to self, when Alex comes on, grill him about the Q-tips.
Yeah, we need to present him with a study or something. I don't know what we need to do. We need him some raw data to look at, because that's unacceptable.
And then one more update. Wearing my Beta Breakers shirt.
What does that mean?
No, I didn't run. I did a 12K. It's an annual race in San Francisco.
Okay.
From here, then you know about it because it causes a lot of traffic issues. But you run from the Bay, which is on the side of the city, to the Breakers, which are the waves. So you run from the San Francisco Bay to the Pacific Ocean.
That's awesome.
If you are a tryhard. If you are like the rest of the majority of the city,
right,
you dress up in a fun costume and you walk it slowly.
And that's what you're going to be doing, I'm assuming.
That's what I did. Yeah, I dressed.
Oh, you did it already. Okay, that's awesome.
As Pitbull yesterday, and 3 friends also dressed up as 3 other Pitbulls.
That is so cool.
Not a dog, but the rapper. And I had a karaoke mic, and we walked it. So
wait, that's awesome. I love that. Yeah. Oh, that's perfect.
Like,
and you need to add like a little clip, like in this, just like insert clip of you.
Insert clip. Yeah. And then what are the people listening just on audio gonna think?
They can pull up.
Maybe I'll put a picture.
Yeah, maybe the album, like
pictures up now, and it'll be on the website, maybe with our source.
Website, yes. On the website.
Anyway, should we do our drinks?
Well, I have to tell you something.
Okay, I'll go first since mine is quick. I know you have a story.
Yeah, I do have a story.
Mine is Teh Java, peach unsweetened tea. Well, Teh Java if it's from Indonesia, and Teh Java if it's from somewhere Spanish speaking, and I'm not sure. So anyway, your turn.
Well, that looks delicious, and I love the cup. The cup has made another appearance.
It's my podcast cup.
Yeah, I really like it. So today I took my exam, and then I went to get a coffee. I ordered it on drive-through. I'm not going to say the name of the establishment because on our very highly viewed podcast, I don't want to bash any companies, but I go to pick up my coffee, and already from the color, I just know that, it's not looking right. I ordered caramel. It looked nothing like a coffee. And then we did a taste test. So we got back to the study room, and my friend, she recorded me tasting this coffee, and it was really, really bad. And you know when you just like need a good coffee to start your day, and it just gets completely ruined. So I was a little disappointed. And now
Have you
I'm
ever considered getting just like a cappuccino or an espresso, like your Italian class taught you to?
well, I could have, and that probably would have been a better option. Unfortunately, I did not do that. And yeah, my day, I don't want to say it's ruined, but I was just,
Severely hindered.
yes, severely hindered. And so now I have no drink. I have no drink to share. It's honestly a touchy. I'm kidding, but no, yeah, that was
Yes,
it. I
this
just,
this episode's off to an awful start.
yeah, Q-tips. Yeah, I don't know. Maybe we
Oh.
give something fun to talk about.
Yeah, we're getting into a bunch of fun topics today. This is kind of an amalgamation of some recent cases.
Sorry, can you say that word again?
An amalgamation.
Oh, perfect. And can you tell me what that means, John?
It's like a group of stuff,
Oh,
random stuff put together.
group of stuff.
So we have a group of a bunch of cases that we're
Mhm.
going to look at, almost like a case report, but informal. And I think that the majority of them are recent.
Okay.
And I think it will just be cool for the audience and for us to discuss this. So I'm going to introduce case number one. This is coming from the Mayo Network. So for the background, we have a 30-year-old Michigander, or I think it's Michigander, who survived a self-inflicted gunshot wound at age 19, which left him with severe facial disfigurement.
Mhm.
So over a decade, he underwent, get this, 58 reconstructive surgeries,
Eight.
but still had issues with speaking, eating, and breathing. Understandable.
Mhm.
After a bunch of other options, his doctor referred him to the Mayo Clinic in Minnesota for a potential face transplant. And so in the last 20 years, there have only been about 50 face transplants done worldwide.
Wow. Okay.
And this is the Mayo Clinic's second ever face transplant. So last year, a team of about 80 medical professionals did a 50-hour operation on him and replaced 85% of his face. And so they used donor tissue from the forehead, eyelids, nose, mouth, jaw, teeth, skin, muscles, nerves of the entire face and neck. And so we're happy to say that post-op or post-operation, the reconnection of the nerves allowed him to regain his abilities like smelling, swallowing, blinking, and smiling, which he couldn't do for 10 years. So yeah, pretty pretty nice news, and it's in my ballpark kind of reconstructive surgery.
Mhm.
And it kind of goes to show how broad of a or how wide ranging medicine can get.
Yeah, I think this is kind of an incredible case because you kind of have a situation where even after, I think you said 58 different surgeries, there was still the inability to do like functions like speaking and eating and, like being able to breathe without any difficulties. And I think it's so incredible that medicine has now developed to the point where you can actually can do a whole face transplant. I know there's only been 50, like you mentioned, but I do find it interesting how, and I don't know the answer to this question, but I'm just kind of thinking like how like the tissues and the nerves were not rejected. Because like I'm assuming since he's had 58 surgeries, he's able to, or he like recovers well enough from all 58 of those, to where
He's
they,
like superhuman.
yeah, like where he's viable to have a face transplant. But it's interesting how like there's not been any immune rejection. I don't know. We learned about that recently. And so I wonder how that works. And I also wonder kind of the ethics behind it. Like there's somebody else and it was just their whole face, like somebody else's whole face on top.
Maybe the donor.
Yeah.
I'm not sure. I assume if it was from one donor, then it would probably be from somebody who died and was an organ donor.
Mm-hmm.
Okay.
Yeah. Um, I think it would have to be a pretty close match because like your skin, I mean, it has like nerves.
Got the dermatology expert
Nerves.
over here.
No, not I mean, we're learning about it's actually our like immunology unit right now and our dermatology unit, which is why I'm wondering like was there HLA matching done or was he on any sort of immunosuppressive therapy? Were there certain drugs that he was given to either pre-operation to prevent rejection from happening or post-operation? Oftentimes, like patients, like let's say if they get some sort of transplant, they might be on like lifelong immunosuppressants that block T cell activation or they suppress lymphocyte proliferation. So I'm assuming that he was on these type of drugs for now the rest of his life, and hopefully has stayed stable since. But that is a really interesting and very cool.
Mayo, get back to us, get back to Mahak on these questions. Is he on immunosuppressants? And if not, how is that possible?
No, seriously. And I wish, you learn about things in school, but I wish like I have all these questions in my head, like how did this even happen? But my question for you is, would you feel like in the future, if this was an opportunity presented to you, or you were given a case like this, is this something that you would take on?
I don't know. That's an interesting question because obviously, as somebody doing a procedure, you want to know that you will have a reasonable likelihood of succeeding, right? And so, for example, when we talk to breast cancer patients at my internship right now, they have to go through all this chemotherapy and possible radiation just to be able to reach the operating table, where the breast cancer surgeon, the oncologist, will say, yes, I think I can get everything out, and have negative margins, which means, the tissue around the excision site comes up negative for cancer, and it means a successful operation. So until the oncologist thinks, yes, I can be successful, they won't take you there. So I'm not really sure how somebody can feel like, let me try this completely new thing and think that I can do it. I think you have to be really good technically, and really honest with yourself about your ability. Obviously, if it goes well, it's really exciting to be a part of it, right? So, yeah, someday to think about. And I think it's really cool. The article had phrased it as, or they discussed the point that it's not really a life-saving surgery because, this person has been able to live their life with, albeit with severe disfigurement, but they phrase it as a life-giving operation because being able to smile and blink and smell and taste stuff is a really big part of your life. So I thought that was really a really cool way of phrasing it.
Yeah, I really like that because it's like you said, it's not about whether the individual has been given life, but it's restoring their quality of life. And I think that is super important. And I think the team who did this, I'm sure the amount of pressure and like that they took on, like I think emotionally it's such like if I was in a team and I had to say like not yes or no, but basically give my input on whether something like this is viable or if it's going to work, just seeing like the outcome of that after it does work and being able to talk to the patient and have them like have a regain of all these different functions that they were not able to do for like 10 plus years. That is really exciting. So I think it's a really cool case. Obviously.
Yeah, I'm hoping this person has been able to get dinner with there's surgeons since then. Um,
Yeah.
so, um, next case we have
Hmm.
is a spinal surgery. So, this is in the field of neurosurgery, not really something that either of us really have that much experience in, but this comes from the Washington Post. And so the depth of information is fine for most audiences. So we have this young adult female who had already undergone 2 prior surgeries to remove a rare chordoma brain tumor the size of a chicken egg, which is quite big for a tumor, for a brain
Hmm.
tumor. And she presented with another chordoma tumor, which was located at the base of her skull and pressing on her spinal cord. So if you can kind of like take your hand and place it on the back of your neck, you can kind of feel kind of where the skull attaches to the spine. And because it was pressing on her spinal cord, it affected her mobility as well as threatened her life, right? And so this case was significant because a lot of the traditional approaches are pretty morbid in terms of how invasive they are. And for this case, they probably would not have worked. So your first thought would be because it's in the back, maybe you could go through the back of the neck, but then you would get obstructed access to the tumor and it was not really in ideal positioning. The second thought is maybe you can go through the mouth, but your mouth has so many germs and so it's a big risk of infection. I think your saliva has more bacteria than your urine, right? So the neurosurgeon who was in charge of this case decided to collaborate not only with a reconstructive surgeon, but a head and neck surgeon, so otorhinolaryngologist. And they thought about an approach of going through the, hopefully this is not too graphic, but the left lower eye socket. And so they had to be precise to a few millimeters, or else they would risk a fatal stroke or loss of movement below the neck. And the neurosurgeon had actually thought about this method before and had published it in a cadaver study, but it was never attempted on a live patient. So, it goes back to that question of how do you know when you can do it, right? You don't want to mess up, but maybe this is your only chance to fix something. And so they had a lot of practice with cadavers, but this was actually their first live patient. And what I thought was really interesting in the article is that the neurosurgeon went to the hospital chapel before the operation to pray for help. I mean, I probably would too because it's such a serious
Yeah.
surgery.
Hmm.
And it seems like it's a routine that this surgeon does before scrubbing into most cases. And so the surgery took 19 hours. I think it started at 8 a.m. and ended past midnight. And the team basically displaced the patient's eyeball and then drilled through the eye socket to remove the tumor, at which point the reconstructive surgeon was able to use part of the patient's hip to reconstruct part of the eye socket as well as parts of the jaw that had been displaced. And so 1 year later, the patient's now doing well. The neck still slightly hurts, but what's also really interesting and a big takeaway that I got from this is that the insurance did not cover the $600,000 required for this procedure, which I think, so maybe we can take our first discussion on the operation itself and then
Hmm.
second discussion on, I want to talk about the insurance. I'm not sure if that's something that's that interesting to you, but this is for anybody who can see kind of the plan of how
Yeah.
they reached the tumor at the base of the skull. So, any thoughts?
So many thoughts.
Crazy, right?
That is crazy. Honestly, my very first thought, like, is if you were in her situation and a surgeon told you, like, I'm going to need to drill through your eye socket to get this out.
And you're gonna be the first one who's
Yeah, to do
no.
this. I've never done this before. You know, I think a lot of times, like, for example, when we talked about the last case, we kind of looked at it through the perspective of the physician, right? Well, how does the physician feel during this? Like, how does the team feel during this? What are the ethics behind this? But I think, like, looking at it through the aspect of the patient, like, how does the patient feel when you say these kind of things, or you're like, this is the only option that's viable for you right now? I think it's so scary, and something that I'm sure with a lot of practice, like, physicians learn how to navigate. But I think it's super cool. Like, I don't even have too much words to say because I think it's so cool. Especially because it's right in the back by your brainstem. And so that's
Right,
extremely critical region. And
right.
you're going through the eyeball, which is extremely critical as well. So um I think does well, I guess my question after all this excitement around this case for you is, do you think this case kind of gives us, is it kind of a breakthrough in surgery for a different method or a unique method through which, like, if this case was to happen again, people would learn from this and use it? Or do you think it's kind of like a one-time scenario that's not to be replicated for the future?
I think that's what they're hoping for, is that it's a breakthrough, because despite having just a couple millimeters of clearance, it is much less invasive for the body. And your skull is, well, your head has a lot of cavities, right? Um, Especially the nasal cavity, which I think they used in order to go from the eye socket to the chordoma. And so these spaces are important, but they're empty. And so if you're able to utilize this as a way to traverse through the skull, then it's much less invasive than cutting through a bunch of stuff, sawing through bone and all that, right? So I think they do intend for this to be kind of the future of neurosurgery for hard to reach tumors like this one. But I'm just happy that I'm not a neurosurgeon.
That sounds
As
incredible.
much as I want to help people, it seems just really stressful, and I applaud those who want to do it, right? But
Yeah, absolutely. I
and
thought
for
it
the
was,
patient, yeah, I forgot. We're doing the patient's perspective. Yeah, definitely crazy for the patient. I don't even know what I would think if a doctor approached me with that. I'd be following them to the chapel as well.
you know what? What I was thinking about was when you mentioned that the physician, like, had practiced on the cadaver, right? Um, Basically beforehand. And it reminded me of my anatomy lab. Also, like to note, I'm not comparing any of this. I'm just saying it reminded me of this
Right,
experience.
right.
Um, so last semester, I was in anatomy lab and we were learning, we have like two classes, like anatomy and then there's DPR. And so you learn how to intubate in DPR. And then like in anatomy, you learn like
We're listening. What's DPR?
a doctor-patient relationship.
Okay.
So that is just a class where you learn like physical exam skills and basically things along of that nature. And so we had learned intubation, I believe, in DPR. And then when we got to anatomy lab, um, one of our scholars was like, you know what? You can learn how to, like, basically do this maneuver on the cadaver if you'd like. And the difference that I felt on the cadaver and actually like learning how to do that versus learning how to do it on like a plastic sim, even though it was so different. And I bring this up because it's kind of like I felt scared doing it on a cadaver. I'm going to be honest. So to feel that fear on a cadaver, but then to actually go into a 19-hour surgery and do it on a real human whose life depends on you, it's just like, I don't think I can even imagine or put into words the fear that I feel in my heart for that.
Right. I think it's great to be religious for your own mental sake, that you can say that somebody is guiding you.
You know, I mean,
And I mean, that's something that I think of because I'm Christian.
mm-hmm.
And it's just, I don't know. I think it's helpful.
My friends and I, we kind of joke. We're like, we kind of forget about religion or whatever sometimes. And then right before an exam or right before something important, you're like, you're like, oh my gosh, like, God, please help me or whatever. And so there's a lot of
Right.
jokes happening that, but it's real because sometimes when, you're in a stressful situation, not commenting on whether you're religious or not, it's like the feeling that
For
somebody,
humans, the extent as a rational thinking human to have the belief that somebody, some higher power can help you, I think would really take the load off for some of these stressful
it
situations.
would take the load off. And if you don't feel that way and you're also able to handle that stress, then I also applaud you for that
Yeah.
because that is that is quite a bit to take on. But
I
anyway,
wanted to bring out the second part, which was the $600,000 price tag for a 19-hour surgery. And then I believe a short stabilization procedure that happened a couple days later. So the surgery is, I'm sure, deemed not medically necessary, and it's deemed investigational or some sort of experimental because it's the first one, right?
mhm.
And that's definitely why it was not covered by insurance. But what, I'm sure you don't have an answer to this, but what, it's definitely something that we have to think about in the United States where we rely on these third party payers, right? If this is the last resort for somebody, then how can we say we'll save your life, but it'll be you need to write out a check for $600,000? I think it's just a crazy thing to think about.
Yeah, I think it's really weird to think about because you you know that this is a life-saving surgery essentially for the patient just because it's never been done before, and I don't understand or really know too much about insurance policies and I'll have to educate myself on that. But um I don't know how you could expect someone to pay $600,000 for a surgery, especially when they need it and it's going to save their life. This is not some sort of elective, like by choice surgery that, oh, yeah, like I want to,
Yeah, I would like for this tumor to,
like for
wow.
this, you need this tumor to be out. And so, um, I don't know. I think it's definitely a difficult question. And I remember I was shadowing a physician and he had prescribed this medication to a patient and the patient wasn't able, so this medication works well for the condition that she had and it was the best kind of like solution at the time. And the patient, she couldn't afford the medication and he so basically gave her an alternative that was covered by her insurance. But then when we left the room, he was like, some days you feel like you wish you could give your own money and just give the patient the medication that they need. And he was talking about how difficult that was to not insert yourself in between the your patients and kind of the care that they're receiving and how to separate yourself from that. And I think that kind of relates to this situation where, I mean, it's just like, I don't know. I don't know. The price is
It's
really,
so hard to be, as a doctor, your patient's advocate and have this area of their life that you cannot help with, really. I mean, you can help to a certain extent, as you said, prescribing some sort of generic alternative, but it's just really difficult to take an oath and do everything for the benefit of your patient and then see, just because of how the system is set up, that they struggle with paying for the care that you are providing them.
yeah.
So anyway, that will definitely be a much longer topic for an episode or a series of episodes, for sure.
Yes.
I have one last case because I think this one's going to be a longer
Okay.
episode, still equally interesting, but this one is almost kind of an opposite tone from the other cases. This is something that did not go well, and it's maybe
Here.
word of wisdom, yeah, for
That's
you as a medical student, for physicians, for patients, for everybody. So this comes from NBC.
Okay.
And we have a 70-year-old man from Alabama who was visiting Florida.
Okay.
And he developed abdominal pain and was admitted to the hospital in Florida last year. His imaging showed hemoperitoneum, which is bleeding in the peritoneal cavity, so abdominal internal bleeding, as well as a splenic injury. And so the recommendation would be to take the spleen out. So last August, a general surgeon performed a splenectomy, or at least what was supposed to be a splenectomy. And I think you'll find this crazy because you are in a cadaver. You do work in a cadaver lab, right? In an anatomy lab with your med school. Instead of removing the spleen, he resected the liver, which, if you have seen the difference, a spleen is the size of about an avocado. The liver is the size of a football, right? And they're on opposite sides of the body.
Absolutely.
So when you remove an organ, you have to sever the blood supply. So in removing the liver, he severed the inferior vena cava, which brings the blood from the liver and basically the lower half of the body back to the heart, right? And so he severed that, and there was catastrophic hemorrhage, and the patient died on the table from blood loss because of the liver resection and the blood vessel injury. So they did an autopsy. Oh, and the surgeon labeled it as the spleen and sent it to the lab after taking out the liver. The autopsy looked at the body and confirmed that the spleen was still there. The organ that was removed was actually the liver, and that the cause of death was what I just said. So the crazy thing is that while the malpractice and wrongful death lawsuit are in the works and the doctor's medical license was suspended in Florida, this is not even the first time that they had something wrong, this doctor. They had mistakenly removed part of a patient's pancreas during a planned adrenalectomy, where you remove the adrenal glands, right? And although that one was, I guess, settled outside of the court or some sort of financial agreement, the pancreas, when you learn about it in medical school, there's so much stuff, and the liver, that you learn about that goes through the pancreas, so that the pancreas is in charge of. It's like, it's almost like a flaw in our evolution as humans that we rely so much on this one organ. So I don't know, it's just crazy. And to think about the difference in size between the liver and the spleen and the different anatomy, it's just completely, I don't know, nuts that this happened.
I think what upsets me about this is, well, first of all, should never happen in the first place. But the fact that this individual was kind of under, I don't want to say hot water, but there was something going on prior, right? Like something had happened before, and then the individual is still able to practice, and then something happens again, and the second time around, it's not just something that can be settled. Right now, we have a patient who has passed on the table. And so I feel like it's upsetting because perhaps if there had been some earlier intervention, and I don't know what the rules are regarding, like different things like this, or how the board handles all of this, like all of these issues, what are the protocols for this? But just as like a general statement, I think if there is something that's already happened and it shouldn't have happened, I think there should be some sort of, either it's a retraining procedure or there needs to be some sort of intervention that prevents things from happening like this. Because, I mean, yeah, the liver and the spleen are very, very different from each other. And it's unfortunate that it has resulted in the death of a patient, It also makes me wonder, and so you kind of, I guess, shadow more surgeries than I have. Usually, is there a surgical there's a surgical team, right, around the
Yeah.
table. And so I think, I mean, not saying that nobody else noticed, but
Yeah,
that's,
actually, what's interesting is that in the articles, it seemed like the nurses and the OR team, having seen many, many procedures, not that they can replace the role of a surgeon, but they also have knowledge that is worth contributing. That's why it's a team, right?
yeah.
They knew, according to the article, immediately that that was not the spleen and was in fact the liver.
Oh,
They actually said they felt sick when they saw that that had been removed, but they had labeled it as the spleen as the surgeon requested. So I guess that begs the question, or I guess it's just, I don't know if it's a question, it's just a topic. You have to trust, your team has to work together well enough where nurses and OR staff feel comfortable telling the surgeon, this is definitely not the spleen. There's something wrong, right?
yeah. I think in that moment, I'm sure the shock and kind of the emotions that went through, like, oh my goodness, I know exactly what happened, and this is what happened, and maybe kind of like a fear of like you don't know what to say. But I
Yeah.
also think, um, I'm just like imagining, like, okay, someone's standing there and they're going towards the liver. Did anyone feel like they could have said, I don't know, not feel like they could have said something, but just, yeah, what you said about the overall team, like, do other individuals on the team feel comfortable enough to say, hey, like, I don't think this is right, or, let's stop for like 30 seconds and see what's about to happen because I don't know, it's kind of scary. Uh, and I'm sure that they're very well, like, they have a lot of knowledge because a team is constantly there for like every surgery.
Yeah.
So,
Well, I mean, when I'm shadowing in the OR, sometimes the OR nurse will give advice to the resident, the plastic surgery resident, and tell them this is where you should clean this, or um, gives them a bit of tips on how to answer something. So they have knowledge that's worth contributing, and the fact that they didn't
yeah.
feel like they were able to say anything against the surgeon's word doesn't spell good news for the sake of it.
Yeah. Just because someone is a surgeon doesn't mean they necessarily know everything all the time, or just because someone has the title of a doctor doesn't mean that they have all the knowledge in the world and that's the end all be all. I think experience is experience, and everyone is well qualified, especially on an OR team. Just speak up, or I mean, obviously they knew what was going on because you stated that they kind of felt sick to their stomachs, and so that is very unfortunate. And hopefully things like this will not happen in the future.
Yeah.
Maybe, yeah,
Well, I guess we should have put that one in the middle and had kind of a good news sandwich. But
yeah.
we're ending on a bit of a sad note, but it's okay. It's learning experience.
Mhm.
I think these kind of things are also important for future medical professionals to read about, right? So,
Yeah, and not everything can end on like a super positive note or oh well, and then this happened and everything is
yeah.
okay. And I think there are lessons, like you said, to be taken. So, um, I know that we kind of just, I mean, I appreciate you presenting the cases and us just kind of talking about how we felt about them, and hopefully this, who to our loyal and many followers, hopefully this is an interesting topic that they can kind of also think about
And I
along
think
with us.
it would be cool if we just did episodes in the future on new procedures or some sort of case, even individual case reports, if there's enough information or, a specific diagnosis.
Absolutely. I think that would be really fun.
Yeah. Well, what are your plans for this week? You've got a lot of the week left. I know you had an exam. It might already feel like forever since your last break, but
Yeah, I think well, I do have some exciting news to share, but I don't know if this is a long enough. Is this already too long? Do I need to save it for the next episode?
there's no rules. Go
Okay,
ahead.
I can't say too much right now. Um, actually, you know what? No, we'll wait. We'll wait till later. But
Oh, come on. You already said a little bit.
well, maybe I can give a broad thing without really mentioning too much. So basically, I'm interested in dermatology. We know that. And I had pitched a project to be able to go to Greece and learn about skincare and their like health, their nutrition, the
Because
way
you're
they're
right. They're pretty southern, and I think they get a lot of sun, right? So
Mhm.
I know melanomas or skin cancer broadly is a topic of interest for you. So I'm sure they deal with a lot of cases, just like Australia.
Yeah. And so I had pitched this as a project, kind of to my institution, and I was accepted from one of, or I don't know how many proposals they received, but I was accepted. My proposal was accepted, and so I do have the opportunity to go to Greece this summer and to learn. And so I'm sure that on our next episodes, I'll have many fun things to talk about my experience.
But
Um,
by the next episode, you'll have already went.
Oh, no, 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 no. I will just kind of be gathering data and stuff. And so maybe I'll provide little updates along the way.
Oh, okay, okay.
I don't
But
go
yeah,
till
we
July.
definitely want to hear once you've gone, any
Yes.
downtime, if you saw any cool sights in Greece
Mhm.
or ate any good food.
Of course, I will. As for the rest of the week, what am I doing? I'm going to study some more. I've got my OSCEs, which are basically like patient encounters back to back. And then I'm going to have a practical on Monday and then an exam next Friday. So pretty booked. What about you?
Pretty booked and busy. Well, I actually have a bit of a light week, so I finished a first draft of a manuscript that I've been working on
Yes.
Friday,
Okay.
and to use the much overused word in my lab, the hot potato has been tossed to somebody else because now my PI has to review.
Okay. That's very exciting.
I don't have anything until I get that back. There's obviously other projects that I need to work on, but that was the main thing. And so I'm actually waiting for review on 2 different things, or maybe 3. So basically, it's out of my hands now. There's a lot, but it's out of my hands.
Basically, it's listen, you did your part and now it's
Yeah, like I wish I could move this along, but I cannot. So I'm gonna sit here and wait.
well, I'm very excited for your project and your
I
manuscript.
know, and I can't wait for our first collaboration.
I know. I'm very excited about that as
It's
well.
got to be. I'm sure by next year we'll have something going on, multiple things.
Oh, absolutely. I think this summer, when things kind of settle and my grades have a final approval, then I'll be able to, you
Yeah,
know,
and the people who read these scientific journals will be like, "What? John Winton and Mahak Sharma? I thought I saw them in the last publication. How come they're in every single every single volume?"
every
Well,
single.
because we're just gonna be that productive.
You know what? I really hope so. I think maybe, maybe they'll be like, what? I just heard them on the Skin and Stitch. What do you mean?
Yeah, true. Or we could slip this into. Do you think that the journal editors will tell us to take it out if we put a plug for our podcast?
Yeah, definitely. We can't do that.
Okay. Well, this episode has gone on for long enough, so I will see you next time. Thanks everybody for tuning in, and tune in again to hear Mahak talk about her project in Greece.
Absolutely. Thank you very much, Sean.
Bye.
Bye.